think we're here today to try and inform as many veterans as we can. We're here with Dr. Bash.
Welcome, Radio Land, TV Land, and YouTube viewers and listeners. This is Dr. Craig Bash. I've been doing veterans medical opinions for 30 years, and I have dozens and dozens of these radio shows which we're going to publish on this YouTube channel, and number 1 through whatever. So thank you for listening, and here we go.
How you doing, Dr. Bash?
I'm doing good. So just a couple weeks ago, I had a patient went to a higher level review, and the patient had me call in on the phone call, and then the DRO said that was the first time he had a doctor on the line. But what was good is he asked me questions, and then he granted the case a week later. So that DRO higher level review process with experts on the line might be a good way to get the cases resolved. You know.
That's good. You hear a lot of good and a lot of bad about the higher level review, because it takes away your avenue for, submitting new evidence. But situations like that, I guess it worked out. So, we always hope
sometimes
things like that happen.
Yeah, Bill's been teaching us about the laws, right, Bill? And so in some of our opinions now, we're putting some of those laws in there. So when you go to higher level review, then you have something to talk about with the law part. Is that right, Bill?
Yeah, and that's why Dr. Bash and I are teamed up, because of my knowledge of what the rating schedule requires, what the manual tells the employee to do, and how to determine service connection, how to evaluate a disability. What I do for Dr. Bash is to make sure he knows the criteria and how these things are interpreted. Then when his opinion and review reaches the decision review officer, there's an outline of just exactly what the veteran wants, why he wants it, what the medicine is that supports it, and what the manual, the regulation, the court case law says for him to do. So if they want to, they can just run right down Dr. Bash's opinion, follow it, and agree, and be done. But if they want to check something, look it up, well, there's the references. I help them find it. So
that's perfect. That's perfect for the higher level review because.
Yeah, but remember now. Yeah. My question is now, the manual says that if you elect higher level review and then you submit additional evidence, take it out of the higher level review and instead assign it as a supplemental claim. So to me, that means you lose your place in line. Now, what I like about what Dr. Bash did to engage in that phone call, okay, he is actually providing testimony that will give the DRO additional evidence without it being kicked out. And that's a brilliant move, Dr. Bash.
Well, sometimes I fall into these things, He asked a couple questions about how I wrote my opinion and whether I thought it was aggravation or direct service connection and things like that, and then he just went ahead and decided it,
So in this case, you had already written an opinion that was part of the record.
Yeah, right.
And then it went into higher level review with the evidence already on hand.
He was asking for clarifications and things like that. Yeah.
There's an example of how to do the higher level review perfectly. Excellent. Way to go.
Well, it's important for you to feed me the law part, because if you go there with just the medicine to the higher level review, then it's not, you can't review the medicine as much as you can the legal parts of it. So it's interesting. You have to have a nicely prepared Nexus letter to be able to make that process work, and that's the teamwork.
Yes, and of course, recall what I referred to as the difference between the practice of medicine and VA's adjudication medicine. They're not exactly the same. Terms have different meanings to the adjudicators, like raters and decision review officers, than they do to medical professionals. And of course, terms change over time. Medical terminology evolves with time. VA does from time to time amend the rating schedule to bring the terms found in VA's rating schedule more in concert with current terminology. But that always lags. There's always a lag between what the medical world is doing and what the VA adjudicators are using in the way of medical terms. I mean, I remember years ago when I was practicing as a representative, the rating schedule still contained the term dementia praecox. Okay? Now, need I tell anybody that term is no longer used? You know, that was a very old term for schizophrenia. So it's and sometimes a rater might read something and take a lay interpretation of what those words mean and fail to comprehend what the medical terminology is and what its implication is on the case. Because remember, decision review officers, raters, they get some rudimentary courses on some medical terminologies and medical and anatomical systems, but they're not medically trained. So, you know, VA doesn't emphasize that. Instead, they teach raters some basic courses about here's some of the terminologies and here's some of the functionality, but they're ordered to defer to the medical evidence, not their own understanding.
So, Bill, we have a new term that just floated out there, this thing called somatic pain syndrome, you know, something that some rater told me about. And then we have that law that talks about pain from an unknown cause. Are those two things kind of the same? Are they talking about the same thing there, or are they doing something different with those ideas?
Well, you know, back in the day, if the report said a condition was psychosomatic, okay, that was the term that used to be used, the raters would interpret that as malingering. They didn't understand that it was an acquired mental disorder. And there was I actually solicited the help of the Department of Veterans Affairs Chief of Psychological Services to intervene in a case. I'd done some business with him, and we had a working relationship. And a case was before me where the regional office had sent a case for his review, and he had opined, and they denied based on his opinion, got to the Board of Veterans Appeals where I was representing the appeal, and I looked at it and I said, I don't think they understand what he said. So, you know, I called him up and asked him for an amendment myself, and fortunately he was gracious enough to do it. So they can understand. The terminology that he used, they interpreted to mean that it was a defect, that it was a personality defect, and not a disability under the law. And that's not at all what the words meant. So his clarification of the word and the diagnosis was enough to demonstrate that the mental disorder actually began during active duty and not before. And so the case was granted by the Board of Veterans Appeals. And it was just an example of the words. I recall a POW, and try to think of the exact term. It was some time ago now, but paresthesias. He had paresthesias of his hands, and he was claiming frostbite. Okay, and he's a Korean War combat veteran. And that's not a stretch there, is it? You know, the doctor wrote, the VA examiner wrote, paresthesias of the hands, history of frostbite. Okay, well, I know what that means. Okay, he's got frostbite hands from the Korean War, and that's leaving him with burning and numbness and tingling and pain. Okay, of the hands. Mm-hmm. Well, the rater denied it. And I walked upstairs and I asked the guy, you know, I'm not sure I understand why he denied it. He says, well, the doctor didn't say he had frostbite. He said he had a history of frostbite. I said, what about paresthesias? He said, well, he could have spots on his hand from anywhere. Oh, I said, I understand. You think paresthesias means spots. Okay. I'll be back in a little while. So I went downstairs to the examiner and I said, hi, got a problem with your exam. Can you help me out? And, you know, we were all kind of friends back in those days. And sure, Bill, what do you need? And I said, well, the rater doesn't understand your terminology. Do you actually mean to say that he has residuals of frostbites now manifesting as paresthesias, numbness, tingling, et cetera? And he says, yeah. I said, okay. Could you just note that on here for me, please, and put your initials next to it? So he did. Walked it back upstairs and I said, here you go. Those aren't spots. Those are neurological symptoms, okay? And he went ahead and granted it that. You know, you can get spots on his hand from anywhere. Ah, okay. Oh. I'll help you.
That's what that law is trying to get around, right, Bill? That whatever Wilkie versus Saunders, where they talk about if you can't diagnose the pain the veteran is experiencing, but it could be related to an event, then they can grant it that way. That's kind of trying to get around some of that stuff.
Yes. Early in the court's jurisprudence, the court decided that pain in and of itself would not be a rateable service-connectable disability. Okay, that there had to be some underlying diagnosis to explain the symptom of pain. And the courts have reversed that now. And, you know, pain is a rateable manifestation in and of itself. And the manual's been revised to make sure everybody understands that. So we shouldn't see that problem coming up. Well, I was about to say we shouldn't see that problem coming up anymore, but it depends on the training of the rater involved. So, you know, I can't imagine now how enormous VA is. The numbers, you know, thousands and thousands of employees all over the country, and trying to get this entire rafter of employees on the same page is extraordinarily challenging. You know, it's just hard to get everybody to have a clear understanding, particularly in this environment where now the compensation service has been revising rules willy-nilly at a unbelievable pace. I mean, you know, it used to take months for a rule change, and my golly, I remember seeing in recent years multiple substantive rule changes per week. You're trying to absorb all these changes all at once. So, you know, from my experience, I can sympathize with those employees for trying the challenges of keeping up with all the rule changes. But nonetheless, I was capable of producing decisions that well in excess of the required level, and still, you know, take time to read the rule changes and review and look for rule changes, you know, on a daily basis, regularly. So, you know, so I'm sympathetic, but I challenge the employees and say, hey, you got to keep pace. That's your job, you know. It's kind of like if you want to be a Marine, you're going to run 3 miles in 28 minutes, or you're not a Marine, okay?
Yeah. The rules for CPT coding I think they had about 500 new changes this year for the doctors and civilian sector. So these rule changes are happening all the time in different places. So it's part of the job.
Sure. I'm sure it's not unique to VA.
Mm-hmm. Hey, Bill, Jay had a question about radiculopathy. Jay, about your shoulder, right? You want to talk about that a little bit?
Yeah,
sure.
Too.
Yeah. Now, a radiculopathy itself, that diagnosis, is not a disability of the shoulder. It's a disability of the neck. And I want everybody to understand that when we say radiculopathy, think of the spinal column, and you have a stack of checkers, and that's your vertebrae. And you have pads in between the checkers, and that's your discs, okay? And that's kind of like, think of it as a very hard jello. Some flexibility, not too much. And think of all these ligaments and paraspinous muscles and all of those attachments as kind of like rubber bands holding this all together and steady. Okay? Mm-hmm. Now, with aging and or trauma, those discs can start having problems. And with natural aging, those discs are going to begin to narrow, and the space between the vertebrae is going to narrow. Now, you have the spinal cord in the middle. That runs north and south. Mm-hmm. Coming out sideways at the same level where there are spaces between those hard discs, between them out comes the radicular nerves horizontally. And when the vertebrae compress those nerves, or a disc herniates or bulges and squeezes on those nerves or nerve roots, that produces neurological symptoms in that nerve distribution. And so we call them radiculopathies because they are disabilities of the radicular nerves coming out of the neck and the back. So that's some of the anatomy, basic anatomy. Now, when these manifestations start, the first thing you need to know is that is an indication of a worsening of the condition of the spine. And the first problem that people cause now, and a lot of people used to do it, people say, I want service connection for radiculopathy. And that's how they phrase their claim. The VA is supposed to understand, but not everybody's perfect, that means a worsening of the spine. So if you have a 20% spine disorder, and now you're presenting with symptoms of radiculopathy, that is a worsening of the spine. Now, why is that important? Okay, 3.402 in the regulations, that governs the effective date for increases in disability. So if your claim is for service connection, what's the effective date? The effective date is date VA receives the claim. But if your claim is for a worsening of the spine, now to include radiculopathy, the effective date is that day on which the radiculopathy presented symptoms, if you filed your claim within 1 year of that day. So at the moment you develop symptoms of radiculopathy and you see someone for it, and it's documented, okay? Even if it's unsure what the diagnosis is, but the symptoms are there, and you file a claim for radiculopathy, and then you get your VA exam, and then you're rated for radiculopathy, the effective date goes back not to the date of claim, but to the date the radiculopathy first presented symptomatically to a compensable degree. So that's why you phrase this as, I want a claim for increase for my neck, now to include radiculopathy. That started, and give them the date. I had this attack of radiculopathy April, okay? Give them the records that show that you sought care for it in maybe March or June. And in those records there, when you saw the doctor in June, the doctor asked you, when did this start? And you say, it started in April. Well, the correct effective date then is April. Okay?
Right.
So that's why it's important to characterize as a claim for increases of spine. Now, the regulations and the manual that M21 governs this and tells the raters just exactly what I told you. So there should not be a problem if there's a well-trained rater reviewing the case. Now, once the diagnosis, yeah?
Oh, yeah, Bill.
Yeah.
Yeah. Well, Jay was asking about his shoulder and maybe carpal tunnel as secondary to weakness. But keep going. We'll pass through that process.
Okay. Now, once we've established that we have a radiculopathy and we have established that it's compensable, now we have to evaluate it. Well, the rating schedule, let's see now, that would be at 38 CFR 4.124A. I remember. and that describes, it provides for the evaluation of the neurological symptoms. And it also provides, I'm clicking to it as we go, specific evaluations for specific nerves under the peripheral nerve section. And it does not include a description of manifestations associated with a particular evaluation. In other words, in other parts of the rating schedule, like when you're evaluating the lumbar spine, the rating schedule says if you can bend 61 degrees or more, it's 10%. If it's between 31 and 60, it's 20%. Okay? Well, the peripheral nerves, the rating schedule, does not provide specific criteria. It only says you get an evaluation for mild, moderate, or severe impairment of the nerves. One exception to that is the sciatic nerve. The sciatic nerve also includes an evaluation for a moderately severe impairment, but only for the sciatic nerve. Now, the DBQ for peripheral nerves has check marks for the examiner to tick off to define which nerve is involved. Now, if we're talking, the upper extremities, we're talking the 5th, 6th cervical nerves. We're talking median nerve, ulnar nerve. So these nerves have a specific pathway, and you can look up the chart online. You can just look up a chart that shows. You can just Google it or search it online, and it'll show you. There'll be diagrams that'll say, okay, well, at L5S1 in the lumbar spine, it runs down the back of your leg and then switches over to the inside of your leg and out your great toe. So you can see what that nerve distribution actually looks like. They're called dermatomes. You can actually see that on a chart. And the DBQ is designed to solicit a check mark from the examiner that says exactly what nerve is affected, and then the examiners to check mild, moderate, or severe. Now, I said the regulation, does not define mild, moderate, or severe. So what does VA do? VA created definitions and put it in the manual. So at M21, Part 3, Section 4, number 4N4, that section describes the definitions VA intends to use for a mild, moderate, moderately severe, or severe impairment of the nerves, peripheral nerves. It also says that however slight, if the symptoms support the diagnosis, the minimum rating is mild. Okay? And in most nerves, mild is 10%.
Right.
Now,
I've got a quick question there, Bill.
Sure.
Say the veteran's on the service connected for left median neuropathy, left phrenic neuropathy, based on the same neck injury. The nerves that innervate the shoulder muscles and the muscles in the shoulder, the muscles have become weakened and they've atrophied to nothing. There's hardly any muscle left. Then the ligaments and the rotator cuff and everything give away because there's nothing to attach to because it's disappearing. Would that be a secondary condition, or what would that do?
Thank you all for listening. That ends this show. And now I'm going to zoom off.